Thank you, Dr. Rigler. I can see that this is a very popular subject. You can let the people in now, Dr. Mulder, anybody that's... The urologist finds the retroperitoneal space a jungle of strange things, and I'm going to try to, in a few minutes, give you a bird's eye view of some of the things that are confusing. And if you'd start with the slides, please. Turn out the lights and start the slides. We'll go rather quickly through this. This is a... That's a surgeon. Could you see that first slide, please? You'll notice how many hands he has. The next slide, please. This is the urologist's view of the intraperitoneal anatomy. You can see what lies in front of the peritoneum. The next slide, which is another one of Mary Jo's drawings, is a rather interesting one showing sort of a sagittal section down through the right side and showing the relationship of the retroperitoneal space and the intraperitoneal organs. And the next slide, we'll see how pain from any one of these structures can get mixed up if the synapses don't work right. And not only does it get mixed up in the patient, but it can in the diagnostician's mind too. Next slide. This is a patient with stones, but the pain was mistaken for ulcer or for back pain for 3 years. Next slide. And here's a patient with a hydronephrosis, which was thought to be, well, his pain was in the right lower quadrant, and this was thought to be an appendicitis, but actually it was a ureteral calculus. Next is an appendicitis, which produced a hydronephrosis, and of course produced urinary findings that were confusing. An appendiceal abscess. Next. Here's a picture of an appendix, retrocecal appendix, lying right next to the kidney, and you can imagine how disease in that organ could easily be confused between the urinary tract and the gastrointestinal tract. That's the renal pelvis that the appendix is lying on. Next. Here's a patient who had a stone. I wish I had a pointer. I'm sorry, I don't. There's a stone up in the left kidney that's blocking, but this was mistaken for an acute abdomen and was operated on as an acute abdomen, which it turned out to be. Next slide is a patient that came in with hematuria and lower abdominal pain. She happened to be a beautiful model from Bullock's, and so the house staff were very interested in her. You notice that there's a shadow next to that catheter, which was misinterpreted as being a ureteral calculus, but turned out instead that it wasn't a calculus. It was finally proven, and it really turned out that she had pelvic inflammatory disease due to acute gonorrhea. The next slide shows a photograph of her, and the house staff at first, next slide, were very interested, but when they found out the diagnosis, their interest waned. The next slide is a patient who had a double kidney, and at this point she had acute abdominal pain and had her appendix taken out, but actually it was due to a pyelonephritis in the lower segment of this double kidney. The next slide shows a patient who had a retroperitoneal hematoma with abdominal pain, and this was a real diagnostic problem, as you can imagine. The next, this is really just kind of a catalog of some of the problems, but I wanted to show as many as I could. Is a man who had a cancer of the stomach, which produced an obstruction of the ureter with a hydronephrosis and a spontaneous rupture of the kidney. The next is a patient who had a cancer that's upside down, but he had a cancer of the sigmoid colon, which grew inside the urinary tract and produced bilateral hydronephrosis and death. The next is a true hermaphrodite who had abdominal pain, which finally turned out to be due to a Mittelschmerz, but you can imagine the confusion that caused. The next slide is a patient who had a retroperitoneal sarcoma, producing this bilateral obstruction and finally death. This is quite similar to a retroperitoneal fibrosis. Next slide. which will be talked about later. This is a child that had retroperitoneal fibrosis. You notice curving of the spine and obstruction of the ureter, but nothing that you could diagnose until you got in and had a biopsy of it. Next slide is a hypernephroma, which invaded the cecum and was mistaken for cecal cancer. Next slide. This patient in 1953 had this, which was interpreted as normal, but it really is a renal tumor. And in 1957, this ruptured spontaneously and was mistaken for a ruptured aneurysm. It was really a ruptured kidney. Next slide. Next is a true hypernephroma, and then the next slide we see the aortogram, which is classic for that condition. Next slide is a patient who had abdominal pain due to a retrocable ureter. Here's one of Mary Jo's drawings showing it. In the next slide, you see the condition with a combined retrograde pyelogram and a catheter in the vena cava. Next. This is a patient who had gallstones, which looked like kidney stones until he was in an upright position. And the next slide is a patient who had kidney stones that looked like gallstones. They were in this diverticulum or hydrocalyx, and they looked like gallstones, but were proven to be kidney stones instead. The next slide shows a patient with a cyst of the tail of the pancreas, which is pushing the kidney down. Appeared to be a suprarenal mass, but actually we can see that it's anterior to the kidney. And the next is a patient with a cyst of the spleen, which produces this massive defect pushing the kidney down. The next shows a pheochromocytoma in a child, which is another retroperitoneal problem. And the next slide shows an adrenal cortical adenoma in a child, clearly visualized with this retroperitoneal gas study. The next shows a patient who had a gunshot wound, which he said he got in somebody's asparagus patch. And it involved his spleen and his kidney. And the point of that is that such an injury may involve both retroperitoneal and intraperitoneal structures. Next slide is another bullet, this time in the bottom of the patient instead of the top. This bullet had been there for 30 or 40 years, and we don't know yet whether it was the cause of this hydronephrosis, although we suspect that it may have been. Next slide shows a very unusual condition. This happens to be a gallstone, which had passed down the GI tract, eroded through diverticulitis coli, and produced this ureteral obstruction. The next. Here's a patient with 3 diseases: diverticulitis, gallbladder stones, and a stone in the ureter, which was the cause of his discomfort at the time this picture was taken. And this diagnosis was made, fortunately, by Dr. Cannon, who was preparing to explore for either one of these conditions, but had sense enough to look in his urine and found red blood cells. Next slide. A patient who had ileus, which is due really only to a catheter in the ureter. Once the catheter was removed, that all disappeared. Next slide. Here's a patient with polycystic renal disease, very early, and which was discovered after mild trauma to the flank. Next slide. Here's a polycystic kidney, and you can see how trauma would easily cause bleeding. Next slide. A solitary cyst shown on an aortogram, and in the next slide we see it filled with opaque material, proving it is a cyst. The next slide shows a renal arterial. That's the previous one. Could we? Renal arteriovenous fistula following a nephrectomy. Not a very common thing, but a very serious thing. You can see in the aortogram the connection. The next slide, please. Horseshoe kidney is another cause of retroperitoneal cause of abdominal pain and ails. Next. Renal infarction, acutely causing severe pain, followed by hypertension. The next is to remind us that this legend says, just tell him you've got prostatitis and then watch his face. Child psychiatrist. But you can imagine that under some circumstances, prostatitis and seminal vesiculitis can cause pain. The next shows a hydronephrosis due to ureteral calculi. Next slide. You can see the non-opaque calculi. And this is often, next please, mistaken for a subphrenic abscess or perinephric abscess. Here we see a hydronephrosis in a child which is due to this thing, and this is a ureterocele attached to a non-functioning double kidney. This is part of the kidney, and the other part of it's here, causing that defect with this huge bilateral hydronephrosis. But all of this part's not visualized. The next slide shows a Wilms tumor, and the next one shows a neuroblastoma, and you'll see how similar those x-rays are, although the real difference is that the calyces are not deformed here, whereas in the previous film they were. And the next slide shows a patient with bilateral Wilms tumor who's still alive after 10 years, which is kind of a local record. And the next shows a patient who had an abdominal metastasis from a cancer of the testis, and the metastasis is what was discovered, not the original tumor. The next is a ureteral hernia, and the next a bladder hernia, a bladder in a hernia. These can all be confusing things. And I think this would be a good place to stop when you turn on the lights and stop the slides. There are many other things that might be mentioned. Trauma, renal stones causing fistula between either the large or small bowel and the urinary tract, hydronephrosis mistaken for subphrenic abscess, bladder diverticulum, aortic aneurysm, hypogastric aneurysm, aortic aneurysm dissecting, non-opaque calculi, endometriosis, cysts of the ovaries with torsion or with rupture. All of these things are causes of retroperitoneal pathology, which, because the diagnosis is not always simple, may lead the urologist into the picture and be a test of his diagnostic acumen. And now we're going to ask Dr. Kaufman to talk about some other examples of retroperitoneal pathology outside the urinary tract. Dr. Joseph Kaufman.
Thank you, Dr. Goodwin, gentlemen and ladies. Dr. Goodwin has described the retroperitoneum as a garden where many things grow, and like most gardens, there are some prized roses, and there are also weeds that grow equally well. And today I'd like to discuss some of these weeds in this retroperitoneal area, which can affect the outflow of urine as a result of extrinsic compression on the ureter. Now, these can be divided into two general categories, the non-neoplastic and the neoplastic processes. May I have the first slide, please? This, and all the lights out, please. This is what Dr. Goodwin mentioned last, namely an aortic aneurysm. It's interesting that aortic aneurysms do not cause ureteral obstruction very commonly. That's because the ureter really is fixed in only two places, at the pelvis and at the bladder, and it is free to swing in the between those 2 points, so that most aneurysms that don't result in retroperitoneal fibrosis as a result perhaps of secondary inflammation, perhaps with leaks, do not cause ureteral obstruction. However, this is one aneurysm where there was peri-aortic leakage of blood, and there was retroperitoneal fibrosis on that basis, and this patient had this bilateral hydronephrosis that you see here, and this was relieved by ureterolysis. The next slide, please. This is another condition, a tubo-ovarian abscess in a young woman who had menorrhagia for a better part of a year and who had 10 days of abdominal pain and fever. She entered the hospital and was found to have a doughy mass in the pelvis, and this picture. She was explored and found to have a right tubo-ovarian abscess, and a salpingo-oophorectomy was done with subsequent resolution of this hydronephrosis. Next slide, please. Now, this is a not uncommon picture. This is a hydronephrosis in a young woman secondary to a corpus luteum cyst. This woman had previously undergone a subtotal hysterectomy for endometriosis. She had subsequently had both ovaries removed for the same disease and had radiation between the hysterectomy and the oophorectomy. She came in the hospital with right flank pain and with a suspicion of a non-opaque calculus in the lower portion of the right ureter. She was explored. She was found to have a corpus luteum cyst, which was plastered against the sacrum and which incorporated with it the lower third of the ureter. When this was freed by lysis and the cyst was removed, she had a good postoperative result. Next slide, please. This condition was first described by Ambrose Paré about 300 years ago. It is hematocolpometra in a 15-year-old girl who had had monthly pain for about 6 months without show of menstrual blood. She also had been having progressive difficulty in voiding and an enlarging abdomen about the size of a 6-month pregnancy. When she was examined, she was found to have this protuberant abdomen, and on rectal examination there was a huge mass. She was catheterized and 800 cc's of urine was obtained from the bladder, and in attempting to do a vaginal examination, the hymen, which heretofore had been imperforate, was perforated with the release of 2 liters of crankcase oil-like blood from the vagina. Now, most cases which have been reported of this entity are actually colpometra rather than hematocolpos rather than hematocolpometra. In other words, most of the time there is obstruction to the urethra rather than to the ureters. In this case, there was the same condition, in other words, enlargement of the uterus by blood, which exists in pregnancy. Next slide, please. We'll show at this picture this girl 7 days after the release of that hematocolpometra with an essentially normal pyelogram. The next slide will show the similarity of that condition to pregnancy. As you know, during pregnancy there is frequently a dilatation of the upper urinary tract, the right more than the left. It usually happens around the 3rd month and progresses to term. It usually takes between 2 and 6 weeks for this to regress following delivery. This may be partly caused also, of course, by the softening effects on the ureteral wall by the progestational hormones. Next, please. Now, this is a case alluded to by Dr. Goodwin, namely a young man who came into the Veterans Hospital with pyuria and pneumaturia and with a past known history of regional ileitis. You will recall perhaps that back in 1948, when Krohn, Ginsburg, and Oppenheimer first described regional ileitis, they made a prominent point of the fact that urinary tract involvement was not uncommon. And so in regional enteritis, not infrequently, the lower ureter is involved by the peri-enteric inflammatory reaction which occurs around the area of the ileocecal juncture. In this particular case, the patient was treated with a resection of the distal ileum and the cecum and an iliotransverse colostomy with a good eventual result. In contradistinction to this, of course, on the left side, the left ureter is usually involved more commonly by peridiverticulitis. On the right side, it is more common with regional enteritis. Next slide, please. And this has already been described by Dr. Goodwin. This is a sciatic hernia affecting the ureter rather than inguinal. This is somewhat more unusual. Next slide, please. This is an interesting condition which has recently come to our attention. It's periureteral varices, and you will see this characteristic scalloping of the ureter caused by, next please, these veins which course around the ureter in this manner. Now, this condition has also been described, particularly on the right side, in association with dilated ovarian veins. We are not sure exactly why these veins become varicose. They're not always associated with venous blockade superiorly. Next slide, please. This is a very interesting woman who was recently in the hospital and who was explored back in 1960 for this condition, which was diagnosed as idiopathic retroperitoneal fibrosis, and in fact, many biopsies were done with that diagnosis being confirmed. She came to us approximately 2 years later with exactly the same condition, having been unrelieved by ureterolysis. And again, she was explored, only this time, instead of a ureterolysis, we performed a flap, a tube flap of the bladder up to this point. Again, we took many biopsies. This was some 4 to 5 years ago, and they were diagnosed as retroperitoneal fibrosis. This woman did well for several years. She recently has had more pain, which seemed to be related to her, it seemed to be cyclic. She was relieved to some extent by progestational drugs. However, she recently came to operation and was found to have lymphosarcoma in this area, and in fact in a disseminated way. So that here we see a case of latent lymphosarcoma, which was misdiagnosed as idiopathic retroperitoneal fibrosis. I think Dr. Martin may have more to say about that in a few moments. I'd like to go on to a few more cases of neoplastic involvement of the ureter. Dr. Goodwin has already described this. This is a patient with reticulum cell sarcoma, patient of Dr. Belt's, who entered the hospital with anuria. Recall that this is not an infrequent symptom of bilateral ureteral obstruction, namely anuria. Next, please. This patient was relieved, temporarily that is, by the passage of ureteral catheters, and the patient had an immediate diuresis of 3,000 cc's in the next 12 hours. This is a Veterans Administration Hospital patient who had an obstruction in the lower third of the right ureter associated with right flank pain and hydronephrosis. A catheter could not be passed beyond this point. Next slide, please. Shows that on exploration, this patient had a fusiform swelling, which was quite discrete, around the lower third of the right ureter. The next slide will show that this was a lymphosarcoma, which involved the ureter, at least into the adventitia of the ureter, but not the ureteral wall itself. This patient was subsequently treated with radiation therapy and did well for 2 years. He was lost to follow-up at that point. Next slide, please. Another case of Hodgkin's disease, which produces a characteristic medial displacement of the ureter, which you will see again and again. Next, please. And this is a patient well known to Dr. Goodwin and me, who suffered severe left flank pain one night when he was watching a boxing match on television, and who was subsequently found to have a non-functioning, non-visualizing left kidney in the early films, and subsequently found to have extravasation of the contrast material in a late pyelogram, as you see here. This man actually was found to have a gastric carcinoma which had spread by direct extension through retroperitoneal lymphatics directly into the lymphatics of the kidney, and then also embraced the upper ureter, so that he had both a lymphatic blockade and a ureteral blockade, and he, for that reason, developed this extravasation of contrast outside of the kidney, because the kidney represented a closed compartment. Next, please. And this picture here is a patient who had a pancreatic carcinoma, another patient who had abdominal pain, undiagnosed at this point, but who subsequently came in the hospital about 1 or 2 months later with anuria. He was explored. He was found to have a diffuse retroperitoneal pancreatic carcinoma of a pleomorphic variety. Next, please. And this is a patient who will not be too unlike the patient who will be described later on this morning, a young man who had an acute onset of right flank pain. It simulated ureteral colic with a stone. We thought that's what it was. He did not get relief from an indwelling ureteral catheter over a several-day period. And he subsequently was explored and found to have a carcinoma which simulated retroperitoneal fibrosis. It was, to our embarrassment later, that a barium enema showed a rectal carcinoma. Next, please. Another carcinoma of the rectosigmoid. Notice the medial displacement of the lower ureters. Next, please. Now, this is a vena cavogram, a normal cavogram for comparison with the subsequent films. Next, please. This will show you one of the common tumors which metastasizes to the retroperitoneal area, in this case, an embryonal cell carcinoma of the testis, producing this characteristic scalloping and the cross circulation, the collateral, to the ascending lumbar and opposite side. Next, please. And this is a further example of a complete obstruction of the vena cava, undiagnosed clinically, as many of them are, but it was caused by a seminoma, which had been operated on some 4 years, just about 4 years earlier, and which produced ureteral obstruction and vena cava obstruction. Next, please. This is a somewhat rare condition, but we've seen 3 cases of this recently. This is a bronchogenic carcinoma, which was involving many tissues by metastatic spread, but in this particular case, it produced periureteral involvement with some infiltration of the ureteral wall. Next, please. And this is a high-power magnification of that. I think that's all the slides. In summary, I'd like to again point out the fact that the retroperitoneum is a site for myriad pathology, that this pathology can only be diagnosed properly if the clinician keeps in mind how various problems can affect the retroperitoneal structures.
Thank you, Dr. Kaufman. We selected one particular retroperitoneal disease for special discussion because it's an enigma. And Dr. Donald Martin is going to tell us about idiopathic retroperitoneal fibrosis.
Thank you, Dr. Goodwin. Now, Drs. Goodwin and Kaufman have given us a panorama of the many conditions that can affect the urinary tract, both primary or secondary in the retroperitoneum. And for a few minutes, we'd like to discuss one very specific and interesting entity and relate it to the urinary tract. In 1948, a urologist named John Ormond reported 2 cases of hydronephrosis secondary to a peculiar process in the retroperitoneum which consisted of a thick fibrous plaque which enveloped and obstructed the ureters in his 2 patients. And in looking into the medical and surgical literature, Dr. Ormond could find no previous description of an identical case, although many years before, an entity called perirenal fasciitis had been described. Since that time, probably many more than 100 cases have found their way into the medical literature, and indeed in 1960, Dr. Ormond made another report in which he had collected some 95 cases of a similar nature. Now, the clinical picture here, the patient's symptoms are rather vague. This is characteristic of this condition. The patients, if they have any antecedent complaints at all, may have a history of low back or lumbar pain. Anemia may be the presenting clinical sign. And physical examination is also essentially unrevealing. Occasionally a patient will be found to have some tenderness in the renal area due to the obstructed kidney. Examination of the urine is very important because there will usually be minimal changes, perhaps a few white and red cells, and usually no protein. This is an extremely important finding because these patients often present with oliguria or anuria. And of course, the patient who presents with anuria, in whom some amount of urine or oliguria, in whom a urinalysis can be made, and there is the finding of no protein, immediately should focus one's attention on the possibility of a post-renal obstruction, since we recognize that most parenchymal renal disease is associated with proteinuria. The characteristic radiographic findings are those of obstruction to one or both ureters. Now, there's a classical picture in which the middle third of the ureter is primarily involved. The ureter has evidence of extrinsic compression at the level of the iliac vessels. However, the obstruction can occur higher or lower in the pelvis, but the 3 characteristic signs on radiographic examination are obstruction of one or both ureters in this mid-third, a medial deviation of the ureter, and the evidence of extrinsic rather than intrinsic obstruction. The pathology here is going to be discussed in some detail by Dr. Wilkerson. However, just briefly, it consists of a dense amount of fibrous tissue involving the retroperitoneal structures, the great vessels and ureters, and causing obstruction to the ureters by extrinsic pressure rather than actual invasion of the ureter or the ureteral wall. The treatment of this condition has in the past been primarily surgical lysis of the ureter, taking it out of this bed of fibrous tissue and either leaving it free in the retroperitoneum or transplanting it so that it becomes an intraperitoneal structure. That is to say, the posterior parietal peritoneum can be closed behind the ureter to separate the ureter from this dense fibrous mass. The differential diagnosis of this condition is all of the things that many of the things at least that we've heard this morning, primarily primary and secondary tumors of the retroperitoneal nodes and structures. In the recent few months, there has been an interesting series of reports linking this formerly idiopathic retroperitoneal fibrosis to a condition apparently related to the ingestion of a drug called Sansert. This is a serotonin antagonist, which is, as are the ergots, is derived from this, I believe it's a fungus that grows on rye, and is used for people with headaches and of a vascular origin. And in the recent urological literature, there have been a series of cases presented in which patients were found to have this hydronephrosis or even oliguria and azotemia with the characteristic changes of retroperitoneal fibrosis, in whom, upon withdrawal of this medication Sansert, there was rather prompt resolution of the hydronephrosis. And many theories have been put forward to explain why this fibrous tissue would be deposited or formed in the retroperitoneum in relation to the ureter on a vascular basis. Thank you.
Thank you, Dr. Martin. Now, the Department of Pathology is going to give us a view of pathology of retroperitoneal soft tumors. Dr. James Wilkerson.
After talking with Dr. Martin about the subject he was going to discuss, we agreed to depart from the subject, the title given in the program, and discuss the pathology of retroperitoneal fibrosis and its relation to other proliferative disorders of fibrous tissue. This seemed to be more pertinent to the program. Grossly, the retroperitoneal fibrosis is found to be a plaque-like mass in the retroperitoneum. It's firm, rubbery in consistency, and varies from anywhere from 2 to 6 centimeters in thickness. It often surrounds the aorta and the iliac arteries, the vena cava, as well as the ureters, and a number of cases have been reported in which symptoms were produced as a result of vascular compression rather than ureteral compression. Both ureters are usually involved, although there are apparently a few cases of this disorder in which only one ureter has been involved. The ureters are frequently pulled medially by the contraction of this fibrous scar tissue, producing the radiologic signs that have been described. The fibrosis extends upward in the retroperitoneum to a level about even with the hilum of the kidneys. It extends downward to the realm of the pelvis and laterally to 1 centimeter beyond the ureters. Each individual case only involves usually a portion of this area, but there has been apparently only one case that has been reported in which the fibrosis extended out of this area. In that case, it extended up to the diaphragm and also surrounded the biliary tree. This area may represent a single fascial compartment, but there is some disagreement among anatomists on this. The microscopic pathology, could I have the first slide, please? The lesion consists essentially of chronic inflammation with marked fibrosis. In this slide can be seen the fibrous tissue, which is replacing the fatty tissue here, and also some infiltrate of inflammatory cells. These inflammatory cells are composed of lymphocytes, monocytes, and some plasma cells. In some cases, there are large numbers of plasma cells present. The nodules of inflammation, could I have the next slide, please, tend to surround blood vessels, although they do not produce the lesion typically thought of as vasculitis. This, again, shows this fibrous tissue with a rather diffuse infiltrate of chronic inflammatory cells. Could I have the lights, please? There is little invasion of the muscle beneath the fibrous lesion. The adventitia of the vena cava may be involved and obliterated. Although the aorta is surrounded, there is usually a cleavage plane present and obvious around the aorta. In the ureters, the adventitia of the ureter may be involved, but the fibrosis does not involve the muscularis of the ureter. Several ideas have been advanced as to the etiology of this condition. One of them has been that this is an organized hematoma, which has been replaced by fibrous tissue. To support this argument is the fact that old blood pigments, primarily hemosiderin, have been found in some of these lesions. However, they are not found in others. Some people have proposed that this is due to seepage of an irritant from the ureters. However, the ureters themselves are usually not involved in any kind of chronic inflammation or fibrosis. One case has recently been reported in which a patient also had other findings that were suggestive of a collagen vascular disease. There is some evidence that the entire disease process is a result of a single insult, which is followed by healing with fibrosis. In the older lesions, the fibrosis consists of dense collagenous tissue with relatively few inflammatory cells. Some people reporting on these cases have described this as having the appearance of a keloid. The lesions, in many cases, do not appear to be progressive. Usually, after ureterolysis, obstruction does not occur, apparently, in most cases. The other related conditions must include the other causes of retroperitoneal fibrosis: tumor, obvious infection, trauma, possibly radiation. In a recent issue of Radiology, there are several cases of lymphosarcoma which produced marked retroperitoneal fibrosis. This, of course, makes a problem both for the pathologist and for the clinician, in that the diagnosis of retroperitoneal fibrosis is essentially a diagnosis of exclusion. You have a lot of chronic inflammation and fibrosis. There's nothing at all specific about this sort of lesion, and to make this diagnosis means you have to exclude all the other possible causes of retroperitoneal fibrosis. Other similar lesions, one is the fibrous periureteritis described by Vest, and this apparently has been confused with retroperitoneal fibrosis, but consists essentially of a lymphangitis of the periureteral lymphatics. The fibrous tissue surrounds the ureters and does not involve the rest of the retroperitoneal space. Sclerosing mediastinitis is a disease entity that is thought to be identical with retroperitoneal fibrosis. One case has been described of a man who at autopsy was found to have both sclerosing mediastinitis and retroperitoneal fibrosis. The sclerosing mediastinitis is not limited to one fascial compartment, obviously. Two other conditions that have been suggested as perhaps related to this are Riedell's struma and the retrobulbar pseudotumor of the orbit. This is more speculative.
Thank you, Dr. Wilkerson. And now, Dr. Eric Fonkelsrud of the Department of Surgery is going to tell us something about retroperitoneal pathology in children. Dr. Fonkelsrud.
Thank you, Dr. Goodwin. This morning I'd like to confine my remarks to the relatively common large retroperitoneal mass which we find in infancy and early childhood. May I have the first slide, please? Many of these masses which we see in infants and children prove to be solid tumors. In fact, over half of the large masses that we see prove to be of this type. The most common solid tumors that we see in this young age group are the neuroblastomas, the nephroblastomas or Wilms tumors, the rhabdomyosarcomas of the bladder, and the teratomas, either the retroperitoneal, the sacrococcygeal, or some of the other more bizarre types. Lymphomas are usually found in a little older age group. Now, these neoplasms generally fit into the most common neoplasms found in infancy and childhood. After the leukemias and the central nervous system tumors, the neuroblastoma, nephroblastoma, and rhabdomyosarcoma are the next most common and probably account for 20% or more of the malignant neoplasms in infancy and childhood. Next slide, please. Briefly, I'd like to mention the way that these patients should be evaluated when first seen by a physician in his office, that is, the young infant or child with a large mass. First of all, it's very important to determine whether this mass is a solid lesion or whether it is in fact cystic or may prove to be a hydronephrotic kidney, polycystic kidney, or that type. The easiest procedure to perform to do this is simple transillumination in a dark room with a bright light. The inferior vena cavogram, which Dr. Kaufman has alluded to, is another simple procedure which can be performed in the ankle of a small infant, and in following through with this procedure, one can also obtain an IVP. The cavogram will determine whether the cava is obstructed. This is usually found with the neuroblastoma as opposed to the Wilms tumor, which may show some distortion to one side. The chest X-ray is obvious. The Wilms tumor metastasizes to the chest not uncommonly. The blood count is obvious. The bone marrow we feel is very imperative in these patients, since neuroblastoma is found in almost 50% of the patients in the bone marrow of these patients. The urinalysis and VMA. VMA is found positive in several of the patients with neuroblastoma, although this test takes several days to perform and is not an emergency type study. The bone survey is also a very important procedure to perform because frequently the neuroblastoma will metastasize to the long bones or to the skull. It's important to type and cross-match these patients as soon as you see them so that surgery can be performed early, and to avoid palpation of the abdomen to prevent dissemination of tumor cells. Early operation, we feel that this whole list of studies can be performed in 24 to 36 hours so that these tumors may be cared for very promptly. The problem with these neoplasms, if one sees a 6-week-old infant with a large mass virtually filling the abdomen, one can realize how fast these tumors grow. If one waits a few more weeks, these are likely to double in size or progress even more than that and even metastasize. Next slide. Now, briefly, I'd like to review some of the types of tumors that we have discussed. First of all, this is a small infant who presented with a large abdominal mass, which you can see in the left flank over here on the intravenous pilot or the caveogram, you can see how this has been distorted somewhat by this large mass in the left flank. This proved to be a hydronephrotic kidney, and this was removed. Next slide. Now turning to the more malignant of the lesions, here we see another small child with a very large abdominal mass. The child is not jaundiced. This is the prep at the operating table. And here is the child after a large neuroblastoma has been removed from the left flank. Here, or the right flank as the case was here. Here is the X-ray of this child with the vena-cavogram again, and you can see calcification in this mass, which is found in a large percent of the patients with neuroblastoma. This is the histologic picture of the neuroblastoma that was removed in this patient. Next slide. Calcification here in the left flank and the calyceal distortion here. There is no calcification in this mass. This is an intravenous pyelogram and shows the rather marked distortion. Here's the large, well-circumscribed Wilms tumor that was removed in this child. Here is the gross specimen and the microscopic in the same patient. Perhaps we can turn out all the lights and these may turn out a little better. Next slide, please. And here's a patient who had a rhabdomyosarcoma of the bladder. Again, you can see the caveogram here showing the obstruction and the large lumbar collateral vessels, which were described by Dr. Kaufman. And here we can see on a retrograde or a cystogram here the marked distortion of the bladder and the left ureter going up to the kidney here. This is the operative view of the same patient showing the large rhabdomyosarcoma which was found. Here's the histologic picture. This child was treated by a radical cystectomy and a Bricker loop was performed. Next slide, please. And here is another less common problem, but also fits in the retroperitoneal tumor category. This is a large sacrococcygeal teratoma. Here is another lesion in a different child. These lesions are really not as malignant looking as, or malignant as they appear to be in this situation. They may have malignant degeneration, although many of these are well circumscribed and can be removed surgically without too much difficulty. Two approaches are used in these neoplasms. One is through the abdomen to control the blood supply and do a large degree of immobilization, and then secondly, posteriorly, approaching it from this side to remove the bulk of the tumor and then close up both sides. Light? Well, this is a brief panorama of some of the more common neoplasms in the pediatric age group, and I would like to re-emphasize the importance of treating these lesions at a very early stage once you have seen the abdominal mass. Thank you.
Thank you, Dr. Funkelsrud. Now Dr. Jack Riley of the Department of Radiology is going to tell us about some of the special radiographic techniques that can be used to aid in diagnosis.
As you have heard, a wide variety of lesions, both neoplastic and non-neoplastic, produce retroperitoneal masses. Just as there is great variation clinically and pathologically, so also the Röntgen manifestations may be quite varied. Generally, the initial radiologic examination performed is the KUB. This may give valuable clues as to the nature of the retroperitoneal mass. However, unfortunately, its reliability is not high. Often, initially, it's difficult to tell whether you're actually dealing with a retroperitoneal mass or whether you're dealing with a large intra-abdominal mass. In this case, it's important to opacify the GI tract with barium to exclude the possibility of an intra-abdominal mass. Also, as pointed out by Drs. Goodwin and Kaufman, you may detect an unsuspected intra-abdominal tumor. Probably the most valuable of all examinations, basic examinations in the evaluation of the retroperitoneal area is the urogram. And I won't discuss this further as it has been beautifully covered this morning. If, after the completion of these basic examinations, there are still important questions to be answered, then there are certain additional radiographic procedures that may be performed. The first of these, if there is a suspicion clinically of adrenal disease, is the retroperitoneal gas insufflation. In this examination, a needle is inserted between the rectum and the coccyx and advanced into the presacral space. And gas is then injected. Either oxygen or CO2 is commonly used. Oxygen has the advantage of slow absorption, and then you can have plenty of time to get good pictures. Whereas with CO2, you have to be blessed with quick-footed technicians and hopefully also quick-witted. However, it is this physical principle that makes oxygen rather dangerous. In cases of fatal gas embolization have been reported with the use of oxygen. If there is suspicion of involvement of retroperitoneal nodes, either by a lymphoma or by metastatic disease, then cavography is performed. This examination is performed generally in adults by the percutaneous insertion of a catheter into one or both femoral veins and advancing it into the cava. It has the advantage of simplicity, the disadvantage of being an incomplete examination, because we see only the right paravertebral area. We don't visualize the left. Arteriography is occasionally of value in retroperitoneal disease. It is most important in the evaluation of renal tumors and somewhat less often with adrenal tumors. The less common retroperitoneal tumors, of which you've seen examples here today, are only rarely studied with arteriography. The most sensitive index as to the presence of disease in the retroperitoneal lymph nodes is the lymphangiogram. This is performed by the insertion of a cannula into a lymphatic on the dorsum of the foot. It has the disadvantage of being rather tedious for both the patient and for the physician. As evaluation of relative degrees of difficulty, it has been compared with the administration of a barium enema to a flea. Also, in rare instances, the iodized oil which is injected may result in pulmonary embolization, which in a patient with already impaired pulmonary function may cause a severe distress. I'd now like to quickly show a few examples of these various diagnostic modalities. That actually is, that's the last slide. Start at the top, please. No. Would you start at the top? There really seems to be a terrible error here.
3 or 4 more minutes.
Okay. This is, well, no, these aren't even my slides.
You gave me case 1 and case 2.
Yeah, those are the final presentations. I want to
see.
Look, could we have the lights on? Well, you just start at the top left.
Top left.
All right. There goes a third of my time. I guess if I really could improvise, I'd just make up the stories as I went along. This is just a summary of the plain film, the KUB findings in retroperitoneal disease. Next, please. This is a survey film of the abdomen, and you notice a large left upper quadrant calcification. This proved to be an adrenal carcinoma. Next, please. This is a gastrointestinal examination in a patient suspected to have retroperitoneal disease. And you'll notice that there is anterior displacement of the duodenum, widening of the loop. This was not a primary lesion of the pancreas, but rather a large accumulation of retroperitoneal metastases in a patient with seminoma. Next. This is a classic urogram showing the typical deformity of the ureter in a patient with retroperitoneal nodes and lymphoma. There is deformity also of this ureter. It's not quite so obvious. Fortunately, a previous uninvolved film was available for comparison. Next, please. This is a retroperitoneal gas insufflation, and you'll notice how nicely the kidneys are outlined in this particular patient. Occasionally, we have difficulty because of the presence of fibrous septa. You'll notice a normal adrenal here, and this oblique view, you can faintly see the adrenal. The recognition of the normal adrenal is not so difficult. The recognition of large adrenal tumors is easy, but there's a difficult area in between where we often have difficulties, particularly in patients suspected to have bilateral adrenal hyperfunction. Next, please. These are additional views. It's important to obtain multiple views to get maximum visualization of the kidneys and of the adrenals. Next. This is just shown to illustrate mediastinal and subcutaneous emphysema in the neck. This actually is not a complication. This is occurs routinely after this procedure, but I think it emphasizes the importance of the dissection of gas in the retroperitoneal space, and I think that CO2 should be used, even though we here have been using oxygen. We now plan to use CO2 and speed up our technicians. Next, please. There's a large adrenal mass lesion. Actually, this is not an optimal example to illustrate the diagnostic ability of the examination. I think you could pick this up with a powerful flashlight. Next, please. This is an inferior vena cavogram. You've already seen examples this morning. This is just a new twist that we have adopted recently, at the suggestion of Bill Pogue, one of our residents. And we're getting a delayed film to visualize the aorta. In this case here, I have outlined the aorta, and the object of this is to determine whether or not a caval impression is due to a tortuous aorta, and also to evaluate the space between the vena cava and the aorta to see if we can detect lymph nodes which we might otherwise miss. Next, please. This is a cavogram in a patient with massive retroperitoneal metastatic nodes from seminoma. Notice the anterior displacement of the cava. Notice the scalloping of the cava here. Next, please. This is a selective renal injection, and you'll notice a normal kidney here, which has been displaced inferiorly. Here you'll see some prominent vessels. These probably represent the inferior suprarenal vessels. I better be careful here. Dr. Goodwin is a particular authority in this area. This lesion is unproven, but we believe that this is a large adrenal cyst. Next, please. This is an aortogram in a patient with a known retroperitoneal mass, and you'll see that the aorta even is displaced, and this is rather uncommon. You'll see pathologic lumbar vessels and a large cluster of vessels here. At first glance, the origin of this tumor is not readily apparent. Next, please. You'll see with a selective renal injection, though, that a large hypernephroma is well seen, and that accounted for this diffuse retroperitoneal spread of disease. Next, please. This is a lymphangiogram in a normal patient. You notice the chain of nodes. This is about the highest level, normally well seen. Next, please. Last one, 30 seconds. This is countdown. This is a lymphangiogram in a patient with lymphoma, and I think you can readily recognize the difference in these nodes and the nodes in the previous patient. These are greatly enlarged, they have a lacy appearance, and here you actually can see a mass lesion. And in summary, I'll say that even with all of these radiographic techniques of a rather sophisticated nature, sometimes we don't answer all of the questions, and there is one further diagnostic examination upon which we must rely. Could we have the next slide, please? Last slide. Thank you.
Thank you, Dr. Riley. I'm sure that Dr. Longmire will approve of that last slide. I regret the speed of time here, but we'll have to stick to it. So Dr. Shapiro is going to tell us about a case, and I'm going to ask the next speakers to stick closely to their allotted time.
Dr. Fist was a 74-year-old actively practicing physician when he was admitted to this medical center in December of 1963 with a chief complaint of progressive and severe swelling of both lower extremities, the left side greater than the right, and severe swelling of his genitalia. The patient had been in his usual state of good health until approximately 9 months before his admission here, when he underwent a fairly uneventful transurethral resection of his prostate. But during that hospitalization, he suffered a ruptured Achilles tendon on the left, which required surgical repair, and the leg had to be casted for approximately 6 weeks period of time. When that cast was removed, the patient first noticed swelling of that extremity, and he treated it himself with elastic stockings. He did well then for 3 months until he took a long automobile trip, following which the swelling recurred and became progressive until the time of his admission to this hospital. The edema involved both lower extremities and the genitalia, but was most noticeable on the left side. The patient at that time also complained of a sense of fullness in his rectum, which he said was almost painful. He was evaluated by his private physicians, who performed an intravenous pyelogram, which showed no visualization bilaterally. A barium enema and sigmoidoscopic examinations revealed diverticulosis of the descending colon and an area approximately 6 inches from the rectum of narrowing, which was interpreted as being simply spasm. The patient was referred to this medical center with a diagnosis of an inferior vena cava obstruction. His physical examination at the time of admission was generally non-contributory except for a certain degree of mental sluggishness and the edema and swelling of the lower extremities and genitalia, the latter being quite marked. His laboratory examination at the time of admission revealed a hemoglobin of 14.9. However, his creatinine was 17.1 and his serum potassium was 6.1. The patient was putting out only very small quantities of urine, and it was felt that the inferior vena cava thrombosis extended to and included the renal veins. A renogram was interpreted as being compatible with this diagnosis, and the patient was treated with a renal failure regimen and received both peritoneal and hemodialysis, and had marked improvement both in his urinary output and in his laboratory criteria. His electrolytes returned to fairly normal limits, and his creatinine dropped all the way to 2.1. Shortly, however, his creatinine started to rise again, and the patient started to gain weight as well. Cystoscopic and retrograde pylographic studies were at that time carried out and revealed a somewhat atrophic but also hydronephrotic left kidney with a hydroureter on that side. At the same time, a sigmoidoscopic examination was attempted, and although it was partially unsuccessful, the area of narrowing, approximately 12 centimeters from the rectum, was once again noted. 3 days later, the patient was taken to surgery.
We have the slides of case 1, please. This is a study done prior to the patient's illness, and you see a relatively normal intravenous urogram. There is a rather small bladder. Could we have the next slide, please? This is a cavogram, which was performed and shows complete occlusion of the cava with an extensive collateral network. And next, please. And this is a film during the patient's final hospital admission, and you'll notice that there is apparently a pelvic mass. At any rate, there's a loss of the normal soft tissue markings. A retrograde catheter has been inserted on the left side. There's a hydroureter. The kidney appears to have been displaced downward. You don't see it very well, and the ureter is extremely tortuous and irregular. Lights, please.
Dr. Fist was an extremely young-looking man. At the time of admission, he appeared less than 60, although he was 74, and up to the time of his terminal illness, or the illness which brought him in, he did 1,000 sit-ups every morning at the age of 64. He was also known as somewhat of a wit. When he was admitted with a hematocrit of 44% and a creatinine of 17, it was realized that he must have a relatively recent renal failure, and for this reason he was placed on the acute renal failure regimen. There were a number of features which were a little unclear, and even initially we were uncertain as to whether he actually had a renal vein thrombosis. There were some features which were uncertain. He was admitted on 12/22. On 12/27, his creatinine had risen to 22.4, and at this time his urine was about 600 milliliters per 24 hours. He was putting out a reasonable amount of urine then. Hemodialysis reduced the creatinine to 11 milligrams per cent, and on the next day, 12/28, he put out nearly 1,700 cc's of urine. We could not explain this. Obviously, this was incompatible with renal vein thrombosis, and his continued diuresis to January 4, about 2 weeks after admission, and down to a serum creatinine of 2.1, made us wonder really what had happened. The recovery was far too rapid to be attributed to acute tubular necrosis. At about this time, despite the fact that he was putting out a good urine volume, his serum creatinine began to rise. Incidentally, I might point out or comment that when his creatinine dropped appreciably, his mental clarity improved, although he seemed reasonably clear at the time he came in and took some interest in the medical management and made some intelligent comments. Subsequently, he became obtunded, and when he cleared up, I went into his room one morning, and he looked up at me and he said, "Doctor, where am I?" And I said, "You're in the University of California Hospital." He said, "Really? I thought I was in hell." At that time, I thought this was an evidence of his wit. Later, he denied that he even remembered the episode. In any case, his creatinine went back up again, and at that time, when the retrogrades were performed, it was found that only the left ureter could be catheterized, and he was extremely hydronephrotic on that side, and the right ureter couldn't even be located because of edema and elevation of the bladder floor. My reconstruction at the time with Dr. Kaufman, who did the retrogrades, was that he had originally had bilateral obstruction, that the left kidney had been fairly impaired by the hydronephrosis. However, that the right ureter had reoccluded, and his left, relatively non-functioning kidney had continued to put out a large amount of urine without really effectively clearing his blood. I think that the major lesson to be learned here is that if one does not have a clear cause of a rapid onset of renal failure, that we are obliged to do retrograde catheterization, even though on the medical service we tend to be over-reluctant in using the catheter these days.
We explored Dr. Fist along with Dr. Maloney because of the possibility of an inferior vena cava thrombosis. When we entered the peritoneum, it was obvious that he had a large retroperitoneal mass, which was nodular and involved most of the structures of the pelvis as well as of the lumbar area. He did indeed have a lot of collateral venous channels, and what was done on him at that time was a biopsy, which of course confirmed the presence of retroperitoneal fibrosis secondary to adenocarcinoma of the rectum. This diagnosis was made preoperatively. The decision had to be made at that point as to whether he should have any palliative procedure, and we elected to do so. We freed the ureters from their cuirass of fibrous tissue and reimplanted the ureters into the bladder. The patient did extremely well, and within 1 month he was carrying a creatinine of 1.4 and was doing well. He continued to be distressed by a leg edema and lived for almost 1 more year after the operation in relatively good health. He refused chemotherapy, and there was no other avenue of relief open to him. Now, I'd like to just perhaps emphasize 2 or 3 points about Dr. Fist's case, which certainly brought home some facts to us in a most illuminating manner. To begin with, he did not show the picture of obstruction. And we must remember that this picture of obstruction that we usually see, namely there may be flank pain, there may be a diminution of urinary output, there may be a renogram which shows an obstructive pattern, may not be present in these indolent obstructive conditions such as retroperitoneal fibrosis. It's not uncommon for some people to come into the hospital with anuria as the sole manifestation, or uremia without anuria as the sole manifestation of an indolent process which engulfs the ureters. Finally, the question, of course, the moral and sociological question of whether a palliative procedure should be done in a case like this. Certainly we are confronted with many problems where the terminal event is one of ureteral obstruction, case in point being carcinoma of the cervix, of course. And we are often faced with this problem as to whether to do palliative procedures, which, as you can see in this case, resulted in some months of fairly comfortable living.
Thank you, Dr. Kaufman. We have such great orators this morning that we're even shorter on time than I thought. We have one more case to present, and it's a question of whether we discuss what's been said up till now and leave out the last case, or whether we go on to the case. Has anybody got any questions or discussion that they want to?
Ask Dr. Farnsworth what's BMA?
What's BMA, Dr. Farnsworth?
That's the phenylamandelic acid, one of the hormones that's secreted by the adrenal tumors, neuroblastomas.
Any other questions? Well, if everybody sticks to their guns, we may get through the next case, which is a very interesting one, too. Dr. Rowe, who's a resident at Harbor Hospital, will present the next case.
This patient was a 67-year-old Caucasian male who was admitted to the medical service at Wadsworth Veterans Hospital with a 2-week history of cough, coryza, diarrhea, generalized malaise, and rather marked weakness. 4 days prior to his admission, he also noted the onset of dysuria, incontinence, nocturia, associated with a rather high fever, chills, and generalized abdominal pain. His past medical history was quite non-contributory. He'd always been in excellent health and had worked up until the onset of his present illness. Physical exam at the time of admission revealed an acutely ill patient who was pale, lethargic, tachypnic, and he had a temperature of 102 degrees. The significant physical findings were bilateral, non-tender, rather marked axillary adenopathy. He had slight dullness at the base of the left lung. His abdomen was distended, and there was a left upper quadrant palpable mass, which is described as being tender and had a smooth edge. Bowel sounds were reportedly hypoactive at that time. Rectal examination was felt to be within normal limits, and there was no occult blood in the stool. His admitting hemoglobin was 10.9 grams. The white count was 11,300. His creatinine was 5.6 with a BUN of 70. Urinalysis revealed 10 to 20 white cells. He had numerous bacteria and occasional granular casts. His differential at the time of admission revealed 97% mature lymphocytes. Urine culture subsequently grew out in E. coli, and bone marrow aspiration was compatible with a picture of chronic lymphocytic leukemia. Within 24 hours after his admission to the hospital, the patient developed pulmonary edema requiring rapid digitalization, and at the same time was started on streptomycin and tetracycline for his apparent urinary tract infection. Patient responded. He became afebrile. His strep was discontinued, and he was started on IV chloromycetin and kanamycin. Several days later, he vomited approximately 200 cc's of bright red blood with no alteration in his vital signs or serial hematocrits. He continued to complain of left upper quadrant pain, and it was felt that perhaps this mass that had previously been described had increased in size. An IVP was obtained, and an urinogram was interpreted as showing no evidence of function over the left kidney. The patient was maintained on conservative medical management. He remained afebrile and reportedly improved clinically during this period of time. He did, however, have a second episode of hematemesis and was given 3 units of PAC cells because of a drop in hemoglobin. In addition, he gradually developed what was thought to be ascites, and paracentesis revealed purulent fluid, which subsequently grew out E. coli. All blood cultures remained negative during this period. He again remained afebrile. Antibiotics were discontinued after 10 days. And shortly thereafter, he was started on 60 milligrams of prednisone a day because of thrombocytopenia. His left upper quadrant mass reportedly became less tender, but otherwise was unchanged. Upper GI series and retrograde pyelograms were obtained, which I believe Dr. Riley will review. Patient on the 44th hospital day, after, as you might guess, a rather complicated course, went into shock, and despite vasopressors and intravenous antibiotics, he expired.
Rehab the first slide of case 2, please. This is an upper gastrointestinal study in this patient, and he was reported to have had an ulcer. I'm not quite sure where the duodenum is, let alone an ulcer or in the stomach. At any rate, he has a large mass on this side here, which is causing displacement of the stomach and of the proximal portion of the small bowel. The mass is non-calcified and its margins are ill-defined. Could we have the next slide, please? This is a retrograde urogram, the same patient, and you'll notice that there's extraordinary deformity of the ureter, that there's some calyceal flattening. There is the colon is maybe normally positioned. You notice a paucity of gas shadows immediately. And last slide, please. This shows a slightly dilated pelvic portion of the right ureter, a deformed left ureter, and a rounded mass encroaching on the infralateral aspect of the bladder. Could we have the lights, please? I'll leave the interpretation of these films to...
Well, thank you, Dr. Riley. I'm going to ask the projectionist to look in the slide box. I'm Dr. Goodwin from the beginning. Slide number 46 in my slide box. Dr. Riley is quite able to interpret those films, but the important part of it is that there's a filling defect in the base of the bladder and a huge mass above it with a kidney displaced laterally. And if you'd show slide 46, this one I showed you earlier, and I told you this is a child with the same deformity that we've just seen. That is a filling defect in the base of the bladder, kidney pushed out, and a big mass here. In a child, we would all think of that, but in a man 70-some years old, we might not, and yet the condition was the same. The patient had a duplication of the urinary tract with a huge, in the case that we've just been presented, a huge pyonephrosis. You could turn on the lights now. And his death actually came as a result of the pyonephrosis and the septicemia. So he had a congenital lesion which had lasted all those years, been compatible with life, but finally was the end of him. And it's my understanding of that case that that wasn't diagnosed until the time of his death. Well, to sum it all up, and I guess we still have a minute or two for questions, I'm going to ask the projectionist to look in that small stack of slides that I gave you with a rubber band around them and pick out the last two slides. And while he's doing that, I'd like to ask if there are any questions or discussion from the audience.
Dr. Goodwin, I think it should be commented upon along the line of the retroperitoneal fibrosis, and Dr. Wilkerson mentioned that at least one case had been reported where this existed along with a mediastinal sclerosing mediastinitis. We have one such patient here in this hospital, a little boy in pediatrics named Jay Brown. And in reviewing this subject a few years ago, actually, I think there were about 6 cases of simultaneously occurring mediastinal sclerosing fibrosis, retroperitoneal fibrosis. And when you see that slide that Dr. Riley demonstrated showing the retroperitoneal air dissecting all the way up into the mediastinal area, it shows that this is really all one compartment. And it's not surprising that this same sort of process would extend all the way up and down here.
Yes, and it's probably the same disease, just seen in a different place.
Actually, we've had primarily, I think due to the interest of the urologist, but a variety of other cases here. I think of about almost 20 cases of this type of disease, involving everything from the bronchus, inferior vena cava, superior cava, ureters, aorta, portal vein, extending up into the root of the mesentery, producing gastrointestinal symptoms, and a wide range and variety of symptoms associated with this very unusual and peculiar condition.
Yes, and you remember a case that you and I saw where it was involving the sigmoid colon as well as the urinary tract. Dr. Melenkoff, do you have anything to add to this?
No, it's just to add to the list of Dr. Longmire,
mentioned we had one case presented as anemia of unexplained origin, which was finally thought to be due to blood loss and turned out to have varices of the upper part of the esophagus, which were missed in a barium swallow because the fluoroscopist was looking for the usual site of varices, and this turned out to be due also to this fibrosis process, which ultimately involved his chest and retroperitoneal space.
Dr. Rigler, do you have anything to add? Anyone else wish to speak? Dr. Solomon.
There was a paper in the JMA a couple of months ago mentioning the association of the administration of the drug Sansert with retroperitoneal fibrosis. Has there been, in general, any suggestion that drugs might be the trigger for this process?
Yes, Dr. Martin commented on that when he was speaking about the retroperitoneal fibrosis, and that observation is continuing to be made, that Sansert at least does seem to be related, and then when it's stopped that the disease goes away. However, whether there are other drugs or not, as far as I know, has not been said. Dr. Wilkerson?
One point in relation to this is, although the retroperitoneal fibrosis is apparently a fairly new entity, the sclerosing mediastinitis apparently is not. There's one case reported by John Hunter in 1757 that is thought by some people to be sclerosing mediastinitis, and this may have some implication about the role of drug therapy in the etiology of this condition.
Yes, the urologists have, since this disease was only described in 1948 in the urological literature, urologists have been asking where was it before 1948, which is a very interesting question. Well, if there are no further questions, and as there are still 2 more minutes left, I'll show, if you turn out the lights, I'd like to show this slide. This is from one of my favorite fairy stories called The Little Prince by Antoine de Saint-Exupéry. And he says, when I was 6 years old, I saw a magnificent picture in a book called True Stories from Nature about the primeval forest. It was a picture of a boa constrictor in the act of swallowing an animal. Here is a copy of the drawing. In the book it said, boa constrictors swallow their prey whole without chewing it. After that, they are not able to move and they sleep through the 6 months that they need for digestion. I pondered deeply then over the adventures of the jungle, and after some work with a colored pencil, I succeeded in making my first drawing. My drawing number 1, it looked like this. I showed my masterpiece to the grown-ups and asked them whether the drawing frightened them. The next slide. But they answered, frightened? Why should anyone be frightened by a hat? My drawing was not a picture of a hat. It was a picture of a boa constrictor digesting an elephant. But since the grown-ups were not able to understand it, I made another drawing. I drew inside of the boa constrictor so that the grown-ups could see it clearly. They always need to have things explained. My drawing number 2 looked like this. The grown-ups' response this time was to advise me to lay aside my drawings of boa constrictors, whether from the inside or the outside, and devote myself instead to geography, history, arithmetic, and grammar. And that is why at the age of 6 I gave up what might have been a magnificent career as a painter. I had been disheartened by the failure of my drawing number 1 and my drawing number 2. Grown-ups never understand anything by themselves, and it is tiresome for children to be always and forever explaining things to them. Have the lights on, please. I would like to draw the parallel of the hat, which is really a boa constrictor with an elephant inside of it, to the retroperitoneum, when it's a source of undiagnosed disease and pain both to the patient and to the surgeon and everybody else trying to make the diagnosis. Thank you very much.
If I may, I just want to announce that these conferences will be discontinued for the summer. Our next one will be October 6th, and I don't think Dr. Longmire knows this yet, but it will be a medical surgical conference in the old style with two real patients out in front here.